Thanks, Russell, and thank you all for being here today to learn about some of the research that we're doing in GI cancer, and to also kind of get an insight, I think, into how these things kind of work and what these big international meetings are about. So I'm going to talk specifically about colorectal cancer. As Russell said, I'm very keen for people to ask me questions as we go through, and at the end, and just one-on-one if you want to sort of ask me sort of questions away from the big audience. But I'm sure all your questions are very good questions, so don't be afraid to ask me questions. Now, ASCO stands for the American Society of Clinical Oncology. And it really is more than just an American society now. It's an international society. It's a huge meeting. As Russell said, we get somewhere between 35 and 40,000 delegates coming there. And the numbers now are roughly 50-50 of American delegates versus international delegates. And there are always plenty of Australians that go there. In fact, I kind of do most of my meetings with Australian colleagues in Chicago. I'm from Adelaide, and so it's a good chance for me to catch up with people from Brisbane and Sydney and Melbourne, because there are quite a few Australian clinical researchers in cancer over there. And it's a broad meeting. It covers every sort of aspect of cancer, solid cancers, GI cancers, hematological cancers, cancer prevention, cancer services. Anything to do with cancer is usually presented at ASCO. And it's also the premier meeting where new treatments are discussed, new clinical trials. And it certainly offers an opportunity for us to get together and communicate and collaborate with other like-minded researchers across the world. And I'll talk through a few studies where these studies are really a kind of a joint multinational project. And so you need a kind of a platform like ASCO to allow this sort of thing to happen. So Chicago is where the meeting was held, and it has been held there for the last 8 or 9 years. For those of you that have been there, it is a kind of an impressive city with the skyscraper skyline. The conference centre is about 5 miles from the city centre. Most of the big hotels are in the city centre. And to try and keep fit, I used to walk to the conference centre and back. It was a good sort of hour walk. And this is part of the walk, so you kind of see the skyline, and that's Lake Michigan as you're walking across. And there's a nice pedestrian sort of pathway. So if you're ever in Chicago, go to the park and walk along the lake, and it is quite a pretty city. This is how it looks at night. This is the river that runs through Chicago. One of the central kind of landmarks now is this hotel building called the Trump Tower. So Trump certainly has a kind of a presence in a city like Chicago, but it is an impressive city by night with all the lights and everything. Now, this is the conference centre, and this is a photograph that I took. I was kind of very close to the front of the conference centre for what amounted to the final session of the meeting. It was the Tuesday morning. The meeting starts on a Friday and it finishes on a Tuesday, and the big main colorectal cancer presentations were on the Tuesday morning. And I sat towards the front of this and turned back and took a photograph just to show you what it all kind of looks like. And also it kind of demonstrates a few interesting things. Firstly, there are people from all over the world there, and we're kind of doing things kind of out of hours, and we're pretty jaded and jet lagged, particularly towards the end. And you can see this fellow here who sort of laid his head back, and you kind of need to if you're towards the front. It's like being at the front of a cinema, so you're kind of looking up, and that's kind of a dangerous position because you lay your head back on a chair and you can close your eyes. The other common thing that you'll see are people like this who've got their heads down on the screen. No matter where you go nowadays, people will have their heads down on the screen, and even though they've travelled halfway across the world and they should be looking at the big screen and what's going on there, there's stuff going on there. But having said that, they now link it all in, so you can actually see a lot of the data on your screen. You can actually present questions to the speakers through your phone. So the technology is being used sort of in that way. But most people are paying careful attention as they should. So I thought, in terms of going through the data, I'd start off with going through a series of three separate studies that really all asked the same question. They were done by different groups. The answers were a bit different. And I just thought I'd use this as an example of highlighting how we do this research and how we try and make sense of the information that we get out of the research and where it all kind of leads to. Now, the first study that I'll talk about is a study that the AGITG were involved in. It's known as the PETAC-6 trial. This trial emanated out of Europe and several European cooperative study groups. Groups like the AGITG were involved, as was the AGITG. And this is a study that's specifically looking at patients who have rectal cancer that is restricted to the rectum. It hasn't spread. And it was asking a question, a clinical question, and that question really was, should we be treating these patients with one chemotherapy drug, or would we get a better outcome if we used 2 chemotherapy drugs? Now, if you add a chemotherapy drug, you'd think you'd get a kind of a more powerful anti-cancer effect, but you may also get more side effects. And we just really didn't know whether the second drug was going to give us enough extra bang for the extra cost and toxicity. So you really need trials like this to demonstrate that the strategy of upscaling the chemo is beneficial. The main drug is a tablet called capecitabine, which we use commonly in Australia. So that's part of the standard of care, if you like. The drug that was experimental was another drug that we use more so in the treatment of advanced bowel cancer, and we do use it in the treatment of stage 3 colon cancer, but its role in the treatment of rectal cancer has been a bit unclear. So this study looked at patients getting either just the tablet, both before and after the surgery. They have surgery as well to remove the cancer. Patients also get radiotherapy before the surgery, and so the tablet's given with the radiation therapy before the surgery. So half the patients received just the chemotherapy tablet. The other half got the injection drug called oxaliplatin, given with the tablet before the surgery and after the surgery as well. So we wanted to know whether adding in that second drug was going to make a difference. The results of giving the oxaliplatin with the chemotherapy before the surgery had already been presented at a previous meeting, and that finding was interesting in that it didn't really demonstrate a benefit in giving oxaliplatin before the surgery with the chemo tablet. So this now is looking more specifically at what about after the surgery? What about if we give the combination of the chemotherapy drugs after the surgery? Will that further reduce the risk of the cancer coming back? Now, this study involved just over 1,000 patients. That was a fairly large study. And you know, when you're doing a study that's going to be that big, this is where you need this kind of collaboration. You need the groups to come together to make it happen. If one group tried to do it alone, the study would take 4 or 5 times as long. The answer would take 4 or 5 times as long to get to. So we want to get to the answers quickly. And this is why collaboration is so important. And that involves coordination. That involves the sorts of meetings that Russell was talking about at meetings like ASCO, where we meet up, the various trial groups sit together and work out how are we going to do this. And then when the data comes through, we kind of sit down and work out how are we going to sort of analyse this and what does it all mean and how do we present this. So there's a lot of communication that goes on. Ultimately, we all want to find the truth. But the truth isn't always easy, so we'll sort of talk about that as we go through the results. Now, this is really the headline result from this study. They looked at the risk of the cancer coming back both around where the primary cancer sat, so around the lower part of the abdomen, the pelvis. They also looked at the risk of the cancer coming back in other areas, because it can come back in the liver, it can come back in the lungs, it can come back in any area. So we looked here at a particular endpoint, at the 5-year time point. What was the chance of having the cancer come back locally? What was the chance of a relapse in a distant site? And what you can see here is that the CAPE alone, the capecitabine alone, the top one here, don't have the pointer, sorry, is a little bit higher than the bottom one. So in other words, the risk of a relapse is lower, was lower numerically, when you give the combination of. So you think maybe the combination is better. However, when we look at the statistics here and we look at the magnitude of the difference, it's small. We're talking about a difference in the risk of a relapse or the rate of a recurrence. It's only in the order of about 2%. And you know, that might be significant. If you do a really big study, though, to demonstrate a difference that's only 2%, and you want to demonstrate that it's a true difference, you really need a very large study. This was a very large study, but 2% wasn't a large enough difference for us to sit back and say, you know what, this is real. This difference is a real difference. These numbers here, we call them p-values. They give us an idea of the chance that this difference is just a chance finding. You know, when you do a study, one's going to be better than the other slightly differently. You're not going to get exactly the same number. So what if that difference of 1.5 to 2% is just a chance? This tells me that there's about a 24% chance this is just down to chance. There's about a 26% chance that this difference is just down to chance. It's not a big enough difference for a conclusion to be drawn that the addition of the second chemo drug reduced the risk of a relapse. So it's kind of a negative study. Maybe we don't really need that second drug. Or maybe there is a difference of only 1 or 2%, and maybe it would have been significant if we had not 1,000 but 20,000 patients in the study, which is probably not going to happen. I'll come back to this at the very end, where we start talking about, you know, a difference that is statistically significant maybe, or not, and a difference that's clinically significant, meaning that, you know, if this 1 to 2% difference is a real difference, we're reducing the risk of a recurrence by 1 or 2%. So if we treat 100 people, we've prevented a recurrence in 2 of them. That could be a real big benefit, and some people would look at that and think, hey, you know, I want that, because I could be one of those 2 people that won't get a recurrence if I have a second drug. We need to factor in the cost, and the cost that I'm thinking about here is toxicity, because that second drug causes a lot of nerve damage. And is the 1 or 2% benefit sufficient to take on board that extra nerve damage? So that's an interesting question, and one of our researchers here in Australia actually was trying to ask that question. I'll come to that right at the very end. So PETAC6 didn't show a benefit, and this is another statistic from that study, and this is where the curves look very kind of identical now. Now there isn't that much of a gap. In fact, these are really the same. This outcome takes into account both a recurrence locally, both a recurrence at another site, and a death from any other cause. And when you add in some of those numbers, you see that there's no real difference. So this study, the PETAC6 study, did not support the use of the second chemotherapy drug. There's another photograph from ASCO. So yeah, the one that I showed you before was more of an auditorium, more of a kind of a lecture theatre style thing. Many of the rooms are these big kind of hangar rooms, and they can fit, you know, somewhere in the order of 5, I think up to 10,000 people. They're kind of massive. Now this is another study, and this is really asking a very similar, or basically the same question, but focusing on the treatment after the surgery, again for rectal cancer. And this was from Korea. They did a study where they again asked, should we be giving just the 1 chemotherapy drug after surgery to reduce the risk of the cancer coming back, or should we be giving 2 drugs? And here they got a different result. This time the combination of 2 drugs was in fact better. This time this p-value, business that I talked about, wasn't 0.24 or whatever it was, 0.26, it was 0.018. And that's where we look at that and we think the chance that these 2 kind of not really different, and this is just a chance finding that there's a difference there, well, that chance is only about 2%. That's what that tells us. So we look at that and we think, you know, there really probably is a difference there, which is really, you know, might be kind of clinically meaningful. So this is one of the other things that we deal with in research. We deal with conflicting data from different groups. And we have to sit back and put all this together and make sense of what this all means. And we need to, through all this information, develop evidence-based guidelines and really inform evidence-based practice. And it's not easy sometimes. So we saw that previous study that might be a small difference. It wasn't quite large enough really to make it to be sort of statistically significant. This one did suggest that oxaliplatin did provide a benefit for rectal cancer after surgery. That's Another photograph, and you can see the sort of the multiple screens and everyone looking at the screens. And this is another study, again, really asking the same sort of thing, only with a bit of a twist at the end. This is a Chinese study. And I was impressed to see that there were a number of Chinese studies now being presented at these big international meetings. The Chinese, as you'd be aware of, big population, they're getting coordinated now and they're doing the big clinical trials and they've got numbers of patients and they can do these sorts of big clinical trials looking for small differences, sometimes fairly quickly through their population. So it's certainly good just to see the Chinese kind of there on the platform and being part of the international kind of group, because this is really all an international global effort, this fight against cancer. Now what they did is the same sort of thing. The first line across there was looking at giving radiotherapy with a drug called fluorouracil, which is pretty much the same thing as the tablet, same sort of drug. And that's all they got, the fluorouracil, the one chemo drug. The second line across there was the addition of the second chemo drug. Now we're again comparing one chemo versus two chemo. They got the two chemo drugs before and the two chemo drugs after the surgery. Now this is where they had a bit of a twist, because they had a third arm and they asked the question. We sort of take it for granted that this kind of is necessary, but they asked, how much, if we give a really good chemo regimen, a strong chemo regimen, and we do a good operation and we really remove it all, do we really need the radiation therapy? That was the question. So that was really interesting. So they had a third arm, no radiation therapy. And they wanted to see how each of these groups go. So with the basic concept of any of these trials is that you kind of follow a set protocol, a set path, and what you're really interested in is down here, how do the patients go? What are the outcomes? Now this I put up just to demonstrate something that kind of feeds in a little bit to a study that the AGITG are supporting, that Russell mentioned, the Reno study. It's the rectal cancer no operation study. Just to make the point that these patients were all set on a path to have an operation. But a significant number in each of the groups, around about 6 or 7%, said no to surgery. And we don't have the exact details as to why, but we do know that some patients will achieve what we call a complete response clinically. You do the scans, you look inside with a telescope and the cancer's all gone. So it's just interesting that a number of patients decided not to have the operation, but they're all included in the analysis. And this study was more in line with the first study from the European group, where we didn't really see a benefit in adding the second chemotherapy drug. And this time it looks the numbers are almost really identical. What was really interesting though was that the group that didn't have radiation therapy, that just had the chemo, seemed to do just as well. So that's kind of raised a question. This study won't in itself change practice, but it does raise the question about the role of radiation therapy. And I think we need more research to work out whether that is a treatment that could be potentially avoided in some patients. We need to work out who those patients are. But sometimes we get results from trials that raise more questions, don't necessarily give us answers. So this is another nice view. It was sort of close to where my hotel was, and you've got the nice sort of river and the boat trips, and I think I was about to head off on my walk to the conference centre when I took that on a nice Chicago day. I'm going to move away from rectal cancer and just move up a little bit and talk about another really kind of challenging clinical problem to manage. And that is cancer of the bowel that is actually spread to involve the lining of the abdomen. The abdomen's lined by a sheet of what I kind of call glad wrap. It's called the peritoneum. And cancer cells can often move from the bowel and settle and plant on this glad wrap. There's an operation that can be done where with a surgeon, a skilled surgeon that knows how to do this sort of thing, could go in and actually remove this glad wrap, remove the peritoneum. It's a big operation. And there have been some studies that suggest that the operation is beneficial and that giving chemotherapy directly into the abdomen, it's heated up, it's given in through a set sort of protocol, that chemotherapy can penetrate into that lining and get rid of more cancer cells. And that may improve the survival for patients with cancer at that stage. And this is certainly something that is practiced kind of around the world. And the evidence to support this has never been entirely convincing. And the French group, this study was done in France, devised a trial where they got the consent of patients up front before they did the operation. They then did the operation, and provided they could clear the cancer, they had to clear most of it surgically. The patients were assigned, and this assignment happened through a computer or an envelope at the time of the operation. So the surgeon's in there and he says, okay, we've done our operation, it's all good, this patient's had a good clearance. I want to know now, should I give the chemo into the abdomen or not? And that process of randomly assigning the patient happened intraoperatively during the operation. And so the surgeon, they kind of had the medicine all ready to go, or they would put it back in the fridge. The surgeon was told, this patient has been assigned to the treatment. And they'd have the treatment, or no, this patient's not going to get the chemo, time to close the operation. So it was a really clever trial. We don't do very many surgical trials. A lot of our trials, I know this involved chemotherapy, but a lot of our trials involve giving chemotherapy A or chemotherapy B or different radiotherapy treatments, but this really involved the surgeons. The French did it very well. So they wanted to demonstrate that giving the chemotherapy improved the outcome for patients. It actually made a difference to their survival. Unfortunately, it didn't. So this study was what we call a negative study. The survival rate was really no different between the group that got the chemotherapy and the group that didn't. So this is the sort of study that could change practice. Now, it's one study, and there'll be others that say we need more studies before we decide to abandon the intraperitoneal chemotherapy strategy. This sort of data will be teased and examined, and people might want to look at a different type of chemotherapy or a different way of giving it before they are prepared to drop it. But I think it's just so important that we look at this sort of data and we gather evidence to support practice, because nobody wants to be doing something that's not really providing a benefit. And with everything that you do, there's a risk and there's a cost. So these sorts of studies are very important, and a negative result is still a very important result, and it may change practice. So that's intraperitoneal chemotherapy. That's another photo along the walk. It's a beautiful, neat skyline. If you sort of go along there, it's amazing how it can look so kind of ordered. It's really impressive. Now, just sticking to advanced bowel cancer, this is another study that asked an interesting question, I think, and this is more about fine-tuning how we give the chemo and how long we give the chemo for, and what kind of treatment we give. This was a study from Italy. They called it Valentino in Italian. They looked at giving everybody 4 months of chemotherapy with a recipe that we use as a standard across the world. The two chemotherapy drugs, again, same drugs that I've mentioned before really, oxaliplatin and fluorouracil. And these patients were also patients that were treated with an antibody called panitumumab. It's an antibody that works against a particular type of bowel cancer, and that bowel cancer is defined by not having any changes in the DNA of a gene called the RAS gene. So we call that gene wild type. It's not mutated, it's not changed. Now, everybody got the chemotherapy for a period of 4 months, and then at the 4-month mark, in one group, one of the drugs, the one that causes the nerve damage, is stopped. Because that's usually what we do. We don't usually keep that drug going indefinitely because of the nerve damage. But they continued with both the chemotherapy and the antibody treatment in a strategy that we call maintenance treatment. It's a way of keeping the cancer under control for longer. In the other group, they said, well, you know, maybe if the cancer is RAS wild type, maybe we don't need the chemotherapy. Maybe the antibody on its own is actually enough, and we can cut out one of the drugs. So they asked the question, do we need to continue the chemo? Is the antibody alone effective enough to keep this cancer under control for longer? So this time we did see a difference that actually favoured continuing the chemotherapy with the antibody. The antibody alone didn't perform as well. That decision about what you do at the end of those 4 months of chemotherapy is complex. But this sort of information can guide you and guide your patients in your discussion. Some patients will decide to stop everything and have no treatment. Some will want to continue treatment. I think with this, at least, you'd be steering patients away from just continuing the antibody. You'd want to keep going with the chemo with or without the antibody. So we need that kind of information, because at least it kind of takes off one of the options, I think, that some people were thinking about. This is what the poster area looks like at ASCO. And one of the really great things about the posters is that you get a chance to really talk with the investigators. You mingle, you walk across, you discuss posters together and the results together. But it's huge, it's massive, it's a bit of a maze, there are people all over the place. But it's intellectually very stimulating. And one of the posters that I came across, kind of saw this, it was the Saturday morning, I caught up with Prunella Blindman, who's a medical oncologist here in Sydney. And Prunella led a very interesting research project where she looked at patients that were involved in one of the studies that the AGITG was involved with. The study that looked at giving chemotherapy after bowel cancer surgery. And patients in this study were assigned to either have a 3-month course or a 6-month course, 12 weeks, 24 weeks. So the study was asking, is 3 months as good as 6 months? But the group led by Prunella also wanted to ask patients something else. She wanted to ask them, if the 24 weeks is better than 12 weeks, how much better does it really need to be? Is a 1% improvement enough? Is 10% what you're after? Is 50% what you're after? And so she asked the same sort of question in many different ways, but the results were interesting and pretty much the same. So there was a variability in the responses. One of the things that I found really interesting, and this kind of says a little bit about how we decide on things, and kind of, it depends a bit on kind of where you are, and there's interesting psychology behind this. But if you look at this area here, the light green is higher than the dark green. The numbers are small. This is really saying that if you're going to survive 65, if there's a 65% chance of long-term survival, how much of an extra survival rate do you need before you say you want the 24 weeks? If the 24 weeks gives you no extra survival, do you want 24 weeks? If it gives you an extra 1% chance of long-term survival, do you want the 24 weeks? Or would you just stay with the 12 weeks? If the 24 weeks gives you 2%, 3%, 5%, and so on. So it's trying to ask the patient, what is the kind of level where you'd say? And these are patients that have been through the chemo. They know what the chemo is about. Now, some of them were on the 12-week arm of the study, and some were on the 24-week. And the light green means that they were on the 24-week, and the dark green means that they were on the 12-week. And I just found it interesting that, when you start talking about a 1 or 2 or 3% benefit, that's pretty small. Even 0%, which is no benefit. But you've still got a number of people in that 24-week saying, yeah, I'll take that. And I think they're just saying they're kind of happy where they are. Maybe they're just sort of expressing an acceptance of where they are. Maybe that's what that's about. When we get to the 50% mark for patients, so that's where half the patients are prepared to accept 24 weeks of therapy over 12. They're really looking for a benefit that's in the order of about 10%. So that 50% mark kind of meets around here. So it just gives us an idea of the magnitude of benefit that patients are really seeking, to kind of turn around and say that's worth it, given the side effects and the risks and the inconvenience. So I think that kind of information is important. Now, everyone's an individual, and there are variations. But I thought that was really interesting. And that was led from an Australian group through the AGITG and part of the Scott study. So I think that's pretty much all I've got to talk about around colorectal cancer. Having said that, I'm very happy to take questions from the audience about anything that I've talked about and about anything else to do with GI cancer. Thank you.
Thanks. I think Chris has given you a fantastic introduction, both in terms of the general sense of what happens at ASCO, as well as a really fantastic wrap-up of some of the key colorectal messages. I'm going to, yep, you ready to go?
This is just going to play in the background?
Yeah, perfect. Yep. So I don't have slides specifically to refer to, but I was going to briefly share my Esco Impressions. It's probably, I think it was my 10th ASCO actually this year. Most of them have been in Chicago. I think my biggest tip that I have learned is having a properly located decent coffee shop, particularly in the mornings. I'm never a morning person, but with the jet lag and the trying to get to breakfast meetings, my current hotel preference is based on the fact that there is a very nice coffee shop nearby that I've discovered that does decent, proper, what we would call coffee, not what Americans would call coffee, which is something more akin to dishwater. So that's been my biggest ASCO tip. But as Chris said, I think the reason we often congregate as Australians is because there's usually only one decent place to get coffee and everyone's there trying to stave off their jet lag. But also because we're very collaborative. And that's always one of my highlights is talking to our collaborators, which we did quite a lot of this meeting, and also getting their impressions on what's going on at the meeting. So it's always feels a little bit like nerd boot camp. Oncologists and for clinical trialists and researchers across the spectrum, but it's just a fantastic opportunity to bounce ideas off other people, and I always come back quite enthusiastic as well as quite exhausted. So it's always a challenging week or so afterwards trying to get on top of things. But I was asked to speak on sort of some focal key messages in upper GI cancer. And actually, while there weren't any sort of major plenary sessions on GI this year, the actual GI oral sessions had quite a mix. In fact, I think one of the speakers' summary talks was a potpourri because as you would be aware, when we talk about upper GI or what they call in the meeting non-colorectal gastro-intestinal cancer, that actually includes a bunch of different cancer types. So at ASCO that usually includes pancreas cancer, gastric cancer, or esophagogastric cancer, esophageal and gastric, liver cancer, bile duct cancer, and small intestine kind of gets lumped in there, but often other sort of rarer tumour types. And this year they had studies on some neuroendocrine tumours, which can be found in lots of different parts of the body, but are commonly found in the gastrointestinal tract, and so got put in there as well. So it was quite a mix. So I'm going to just do a selection from amongst those talks because there was really quite a lot to try and take in and sort of explain. And I think the ones that are going to potentially affect practice and also that informs some of our current and future trials are probably the keys in terms of thinking about what the changes to practice are going to be. I think the scale of the meeting is both encouraging in terms of the extent of research and collaboration that's going on, but also, I guess at the same time, quite confronting both in terms of the practical aspects of trying to navigate a 40,000 person setup, but also recognition that cancer is such a global problem that we've got proportion only, and it's a significant proportion, but even just a proportion of the sort of international workforce attending, and it's that many people. So I'm going to focus on some of the trials that will probably already be changing practice in the last few days in terms of what people will do in the clinic, but also I think in both a positive way in terms of new things that we now have to offer, but also important negatives. So in a similar way that Chris talked about some negative trials, things that got an answer, but the answer was not what we expected. Even though people and the media like to talk much more about the things that were positive, the new things, the things that were better, equally the things that are definitively not better can also help inform our practice. And I think that's also important to talk about and not just talk about the new, better, shiny things. So I wanted to talk about 2 trials in pancreas cancer. One of them garnered a fair bit more attention than the other, at least on social media. But I think both are quite important in terms of the shifting paradigm of how we manage pancreas cancer. And AGITG has done some recent trials that fit very well, or at least ahead of that paradigm. And these trials one of them at least supports the need to change the way that we approach pancreas cancer. So the Protégé trial has also got a couple of other acronyms because it was a collaboration of several groups. But this is a trial that was led in France by their collaborative group. And it basically took people whose pancreas cancer was considered to be what they call traditionally resectable, so able to be completely removed or expected to be completely removed at surgery. So confined to the pancreas and maybe some of the lymph nodes in the area, but not involved with any of the local structures, blood vessels and things that might make it complicated to get it all out. So in people who had gone through basically a Whipple's procedure or something similar, and were fit to start chemotherapy after that, they were given one of 2 different types of chemotherapy. And the standard treatment, which until last year had been the standard treatment for many years, called gemcitabine, which is a single drug given intravenously 3 weeks in a row on one day and then a week off for 6 months. So they got that treatment, or they got the newer treatment. And there's a few caveats about that newer treatment. They did this trial on the basis that the newer treatment, which is referred to as modified FOLFIRINOX on the sort of acronyms of the 3 drugs it contains, which is 5-fluorouracil, oxaliplatin and irinotecan, all of which are drugs that have been around for some time. They took that trial from the advanced setting. So they've previously done a trial that was published a few years ago that showed that compared to gemcitabine in people with established metastatic or stage 4 pancreas cancer, that the combination treatment is more effective than the gemcitabine. So they then decided, well, if it's more effective in people whose cancers are established, it helps them live longer and feel a bit better for longer, then we should see if it works better at mopping up the cancer than the standard treatment. The caveat on that being that 3 drugs, as you would expect, is a lot more toxic than just the one. The patients that would have been put into this trial, and there are about 500 of them, are people who are going to be probably a lot fitter than some of the other trials that have been done in the past in this setting, or certainly a similar trial that was reported last year that just looked at a combination of 2 chemotherapy drugs, the gemcitabine plus an oral version of the 5-FU called capecitabine. So in sort of trying to tee the numbers up, because the numbers looked a lot better for many patients in this trial, it's important to sort of keep in mind that people who've been through a Whipple's procedure are often very unwell, and in this trial they did allow them 3 months to recover before they had to start their chemotherapy, because it often takes that long. But people who are fit for having 3-drug chemotherapy is certainly not going to be everyone. So while there were some very impressive results, and they found that the actual survival of patients who got the 3-drug combination was quite a lot more, not quite double, but at least 1.5 times longer. And also the time until the cancer came back was a lot longer, which is also important. While that was the case, this is not going to be for every single patient that is going through that procedure. I think what it also supports, and not surprisingly, there were a lot more side effects in the people that got the triplet combination. What it also supports, though, is the fact that systemic therapy for pancreas cancer is an important part of treatment. And the traditional approach, which this trial took, which is that if you can cut it out, you cut it out first and then you give the chemotherapy, is still a very reasonable thing to do. But the significant gains in survival by sort of upping the chemotherapy certainly make the timing of the chemotherapy also a really valid question, and that's the next trial I'm going to talk about. Treatment about pancreas cancer, and keeping in mind that, as we said, only a small proportion of patients will be suitable to have an upfront surgery at the time that they're diagnosed. There's another proportion of patients who will have what's called borderline resectable disease. So disease where you wouldn't necessarily want to go straight in and cut it all out in case you left a bit behind, but you think that you might be able to. So there's a little bit of uncertainty, not clearly going to get it all out, but certainly you might need a bigger operation, but potentially could take it out. And the difficulty in that sort of definition and asking for details, and the reason I won't go into it, is that there's lots of different places in the world where they disagree on some of the minor details about how you determine whether it's completely resectable or not immediately resectable. But the trial called PREO-PANC, I love all the acronyms, so basically pre-op with pancreas cancer, they took patients that were in theory fit and suitable to have their pancreas cancer cut out immediately, as well as some patients where they had slightly more cancer than that, but not so much that you'd say the surgery would definitely not be an option. And then randomise them either to have standard treatment, which is the same sort of standard treatment in that previous trial arm, so surgery and then 6 months of gemcitabine chemotherapy, or they gave them what we call neoadjuvant treatment, so treatment prior to surgery. And the treatment was a few cycles of gemcitabine, and then gemcitabine combined with a short course of radiation. So a little bit shorter than what people often give for radiation when there's not any surgery planned. So it's 36 fractions and a sort of slightly smaller dose, but nonetheless they got those two treatments and then surgery and then a bit more chemotherapy. So it was kind of splitting up the chemotherapy to before and after the surgery and then adding in some radiation before the surgery. And that's actually an approach that is done or now done in a lot of other cancers on the basis that we know that the problems with having some of those treatments after surgery is that often people are very sick and they can't have the treatment. And if it's the treatment that's benefiting them, then they potentially do worse if they miss out on having the chemotherapy afterwards because they can't have it at all. So giving it beforehand, often people cope with it better because they're not struggling with post-operative recovery. And the caveats in terms of the potential cautions around doing it beforehand, because you'd say, well, why not just do it all beforehand then if that's the case? There's always a couple of concerns, and one of which is that the surgeons get a little anxious about the potential increasing complications from operating on tissues that have had radiation and chemotherapy affecting them, particularly the radiation. And the risk of increasing the side effects and the complications with surgery. And also the other concern that often patients have is that the cancer might progress before they get to surgery and they wouldn't get the surgery. And both of those are reasonable concerns, and one of the appropriate reasons why we need to actually do clinical research. We need to look at what actually happens in reality. And what this trial showed is that definitely in the borderline resectable, but also in the people who were immediately resectable, they did much better from having the preoperative treatment in terms of some initial results about the time until the cancer came back, and also some slightly immature results, so needing a bit more follow-up, needing a bit more working out what happened to those patients, but in terms of overall survival. So both of those things are very, and safety results were not significantly compromised. The other thing that I thought was really interesting in that setting is that they saw that despite the fact that actually a smaller proportion of patients, only just, but about 10% less patients actually got to surgery in the group that had the neoadjuvant treatment first, which actually sort of speaks to the fact that surgery is possibly a bit less important than a lot of people think it is in pancreas cancer, and that the pancreatic cancer is a cancer that tends to spread early, so it doesn't necessarily have to grow very big before it wants to shoot off elsewhere. So the role of and the timing of systemic therapy in pancreas cancer is something that we need to keep working to optimise. And some of the current and planned AGITG trials that are working on moving the treatment earlier and the best treatment, I think are even more interesting in light of this research, because the chemotherapy that was used in this trial, the PREOPANC trial, is the standard gemcitabine. And we know that, and that's because when the trial started years ago, that was the best chemotherapy. But we now know that we've got the triplet combination, the FOLFIRINOX, that works better in the advanced setting as well as the adjuvant setting, as well as some degrees of combinations in between that probably have slightly better activity than gemcitabine alone, with maybe not as much toxicity as FOLFIRINOX. So these sort of trials are likely to change practice in a lot of centres fairly immediately, but also I think raise other questions, which is, well, we've got information to suggest that we can potentially do better. We should be doing the next lot of trials to improve on that situation further and work on things with the newer treatments and the newer radiation techniques, which is the other thing that that is emerging. So I thought those two trials together were, on the surface of it, potentially conflicting. You say, well, you've got these two trials. One says do surgery first, then do chemotherapy, and the other one says don't do surgery first, but give this other treatment. You could say, well, which way do we go? They're both actually good trials, and I think the reality is that you can potentially do either. And we will be having a very interesting discussion now at Alpha GI-MDT on Monday, I have no doubt. Our surgeons are always asking us, when's the next trial, when can we put people on? And with that in mind, we're also eagerly awaiting the results of the GAP trial, which is a AGITG trial that looked at a similar population but just one arm and looked at slightly more modern chemotherapy. So we're hoping for some updated results on that soon. And there's also another trial going on that Australian people have recruited to, not an AGITG trial, but that looks at a slightly different treatment given after surgery. So there's lots of things that we still don't have answers to, but we've got lots of potentially better options for our patients as of straight away, which is encouraging because we need them in pancreas cancer. So I was delighted that there were several different trials in pancreas cancer, and initially a little bit puzzled about how to put them together, but it certainly was encouraging. This year there was one of the plenaries was in genital urinary cancers, in kidney cancers, and it was looking at whether or not you actually get a benefit from taking out someone's kidney if they've got metastatic disease and they're having, if they're having good modern targeted therapy. Because they'd had some previous research to suggest that with some of the older style therapy you did get a benefit, but no one knew the answer. And the trial was actually led and presented by a genital urinary surgeon, a urologist, and who basically said, some of my colleagues thought I was crazy for doing a trial that potentially shoots our practice in the foot, and he actually had a lovely cartoon of speaking in his French accent. But he said, but it's critically important to answer these questions. We need to know. And that trial actually found that there was basically no benefit for the type of patients they put in the trial from taking out their kidneys, which is actually a really important thing to know. And most surgeons actually don't want to operate on people, particularly if they know it won't help them, because they understand better than anyone the risks of doing it. And one of the ways that we manage most cancers, or part of the process, is through multidisciplinary team meetings. They sort of function slightly differently in each centre, but effectively all new cases of pancreas cancer in my centre are discussed through the MDT, and the surgeons that we have working with us have sufficient expertise and caseload to be a centre for managing pancreas cancer. So the first thing would be to say that not any surgeon should be operating on pancreas cancer in the first place. That would be the criteria. And they should always be part of an MDT in terms of making those decisions, which tends to be the practice, at least in the places that I've worked and currently do. Surgeons are an important part of the decision making, but they need to be up with the evidence as well. So like I said, we'll be having very interesting discussions on Monday. We've already circulated some of the abstracts, and we do that regularly when we come across things at our respective meetings or journals and for discussion. My argument would be that if you have a colleague who doesn't listen, that they should be gently educated into the fold, and if your surgeon won't discuss current evidence, then you should find another surgeon. Well, they're as much cancer treatment as, they need to know the place of surgery as much as we need to know the place of chemotherapy, and I don't give radiation, but I need to know the place of radiation as well. So my surgical colleagues are actually always asking for when's the next trial coming that they can put people on, because they know how many unanswered questions there are in pancreas cancer, and at our centre we consider appropriate clinical trials as the best form of treatment for patients where they're available. And that's consistent with best practice. So the discussion I'll be having on Monday will always be, first of all, is that a suitable option for the patient? Are they fit for it? And then we'll be having some discussion about whether or not they're better off having more treatment beforehand or having more afterwards. And one of my criteria for deciding would be their general fitness, because the first trial I presented is really going to be a fairly select group of patients. It's a chemotherapy regimen that we do sometimes give in other types of cancers that are very advanced. So we have experience with it, and it's definitely not for everyone. If people are assuming they're going to get those benefits, but they never get to the chemotherapy after the surgery, that may not be a better outcome. So we'll be having discussions about that. There's always the technical considerations with pancreas cancer. We talk to our gastroenterology colleagues that do the endoscopic ultrasounds, what vessels are involved. We've got specialist radiologists. So all of those usual considerations about can we get it out and can we get it completely out, but knowing that if not, or if there's any questions, we know now that there's some better options, or at least good options for giving treatment before surgery. And so that adds an option for many patients, which is exciting. I might move on. So my last talk is going to be, or actually two last talks are slightly different, and they're more about gastric and gastroesophageal cancers, so stomach cancer and esophagus cancers. And one of the reasons why I wanted to talk about the Keynote 61 study is because it wouldn't be a cancer talk these days without some immunotherapy creeping into the mix. But actually, more importantly, because it references my comment about the importance of actually having trials that are definitively shown that something doesn't work. And the importance of doing proper clinical research and not just making assumptions from lab tests and early trials on how something's actually going to work in a group of people. Is this trial basically demonstrates what a lot of people had been suspecting, which is that even though immunotherapy for gastric cancer can help in some circumstances, it's not going to help in all. And it certainly doesn't seem to help anywhere near as much in stomach cancer as it does in other types of cancer. So this trial, Keynote 61, was done in a bunch of different countries, including some investigators from Australia, but it was a pharma-led trial. And all the patients going into it had to have had some chemotherapy already for their incurable gastric cancer, so they all had to have stomach cancer that had spread, or cancer from the esophagogastric junction, so the join between the esophagus and the stomach. And all the patients in the trial had to have had what we'd call a fairly standard combination of at least 2 drugs to start with, and that they'd either stopped responding to that or stopped tolerating it. And the treatment they were given in this trial of about 800 patients was selected down to either standard treatment, which is a different chemotherapy called paclitaxel or Taxol, that's given 3 weeks out of 4, once a week as a drip, or they were given one of the newer sort of immunotherapy drugs called pembrolizumab, which is given as 1 drip every 3 weeks. And we know that some related immune compounds seem to have some benefit, although not a huge amount, when they're given after 2 different lots of chemotherapy has stopped working and when they are compared to sort of no treatment at all. So they sort of said, well, if it's a little bit better than no treatment at all and it's quite safe, let's see what happens when we do it instead of chemotherapy, because we think it's going to be better. And that's not in fact the case. So not only was it not better, or not better enough, it didn't make any difference to how long people stayed alive or how long until their cancer grew in any meaningful fashion. But for some patients who were defined as sort of not having any expression of a biomarker that might encourage a response to this treatment, but for those patients there was a suggestion that actually they did better on the chemotherapy. There was a bit of tweaking, a bit of trying to work out, well, is there a group of patients that did actually get benefit from the treatment even though it's not the original group we thought? And maybe some people who have particular types of cancer, including those that are more likely to be related to Lynch syndrome or underlying genetic defects, maybe they get a little bit of a response and a little bit of a benefit. But for the original group that they selected out who had some evidence of this biomarker, they didn't seem to do any better. They got some different side effects, but and they were all consistent with what we know about immune therapies. So fatigue, colitis, diarrhea, hormone upsets, a bunch of things. They didn't get the side effects associated with the Taxol, but nor did they get any meaningful benefit. So that was I call it an important negative. There was a lot of hype around immunotherapy in general, and always a lot of hype about this trial when it sort of originally set out. It recruited very quickly relative to what was going on because everyone was excited about immunotherapy, but it doesn't seem to be any better. So that's important to know because we don't want to be offering people something that doesn't really help them. And also, apart from the toxicities, it has other toxicities, including the kind of incredible expense. So, so that was an important negative. But another important positive, which is actually about prevention, and I'll just mention it because it was an astoundingly well done study. But we know that a number of people who have gastroesophageal junction, so at the end of the swallowing tube cancers, that actually arises from a condition called Barrett's esophagus, which can be associated with sort of reflux and similar signals into the lining of the esophagus that with time can turn into cancer if it's left. There's been a very, very large study done of 2,500 patients followed for about 9 years average. So the total study, and from when they started until they reported this, was 19 years. Big study looking at patients who have Barrett's esophagus, who are high risk for developing esophageal cancer. Can we prevent that? Can you reduce the chances of them getting cancer? And they showed that they looked at 2 things. They looked at aspirin, and then they looked at 2 different doses of a proton pump inhibitor, which are drugs that are designed to sort of reduce acid in the stomach and potentially reduce reflux. And they showed that when you give a high dose of a proton pump inhibitor, as well as then combining it with aspirin, you get the biggest effect. And you can potentially reduce the number of cases by enough to warrant potentially doing that without a lot of side effects. And they also showed that the aspirin alone didn't do very much, and that the low dose PPI did not a huge amount on its own. So the 2 bits together were the key, and the adverse events were actually really low, so less than 1% of patients. Because always we do worry about giving people drugs that can have side effects, even if they're relatively mild. If you're going to take them for that long, for that amount of time, forever, basically, then you worry about the side effects. So, it was an incredibly impressive effort from the patients and the study team, and I think is really encouraging because it means that we might be able to prevent people getting esophageal cancer, which is definitely a good thing to prevent. So, so I was very encouraged about that, even though it wasn't a traditional chemo drug. Certainly chemo prevention in the best possible way. Yes, and that will likely start to change practice immediately as well because we have access to both those things.